A very good evening to one and all. So, myself, Dr. Monika Kankarwal, Faculty Nursing College, AIIMS Deogarh. So, as you all know, that today is a very important day since we all are celebrating World International Women's Day. So, happy Women's Day to all the beautiful women around us. And also, many of us are very excited regarding the T20 World Cup match between India and West Indies. So, let's pray for both the team and hope for the best. So, being the very important day, the class do is very important, and the topic which is being covered by me is very crucial from critical care viewpoint. So before starting my class, I just want you to have an overview regarding a case scenario, which usually you will encounter in the ICU setting among your patient. So this is a real case scenario from ICU setting. So there was a 58-year-old male patient who was admitted to the ICU with a complaint of fever, breathlessness, and confusion for 2 days. He was having a known history of diabetes 2 mellitus, and the patient was hypertensive also. So the initial clinical findings suggest that the patient was having temperature 102 degrees Fahrenheit with the heart rate 118 per minute, bit tachycardic, and also the blood pressure was being 90 by 60 mmHg, hypotensive. And the SpO2 88% on room air with altered sensorium. So if you clinically think about this patient, then it will suggest you that patient might be suffering from severe infection, right? But what type of infection and what is the severity of that infection and what measure the organ might have involved? I think this you won't be able to get clear picture with this type of clinical presentation. So to be more clear and precise, the urgent lab investigation was sent for the patient, and the lab investigation was CBC, C-reactive protein, serum lactate. So, based on the lab investigation values, it was found that patient was having elevated WBC count, which was 18,000 per milliliter cubic. Also, the C-reactive protein of the patient was markedly significantly elevated, which again was an indication of having the severe infection, with the serum lactate 5.2 millimole per liter, indicating tissue hypoxia. And also the procalcitonin level was high, suggestive of bacterial infection, with altered ABG, and patient was bit toward metabolic acidosis. And the blood culture sent shows the Klebsiella pneumonia. So now you can see that yes, the patient is having infection, but what type of infection, to what severity the patient is infection, to what basically the organ involved, and what organism the patient might be infected with. So now we are very precise and peculiar. So clinical assessment will raise suspicion, but laboratory investigation will confirm severity, will guide you in treatment and monitor progress. So early lab values clues saved alive. So with this note, we'll start our today class, which is being regarding the importance of lab investigation in ICU survival, and which is also considered as a diagnostic backbone of the ICU setting. So there's a famous saying by Peter Safar, who was a father of modern intensive care, who says that the intensive care unit is a unit where physiology is being continuously measured, interpreted and acted upon, and that can only and only done with lab investigation. So he was the one who believed that lab investigation plays a vital and crucial role in identification and in caring for ICU setting patient. So let's talk more about it. So the objective of the today class is regarding the importance of lab investigation in ICU setting, common laboratory investigation carried out in an ICU setting. So we'll talk about those investigations, what are those investigations and how they are carried out, what are the various nursing role in performing those investigations, each in brief in further slides. Also, we'll talk about the point of care setting, bit about point of care setting in ICU setting, and finally concluding our class. So importance of lab investigation. So with the case scenario, we understood that how crucial the lab investigation is. And lab investigation is an integral part of a therapeutic approach in ICU setting, which helps in clinical problem solving, which helps provide a mindful pretest probability of the disease condition, and also assess the performance of the selected test with the relative benefit and risk of testing. Also, lab investigation, considering the indication for a particular test can lead to more rational approach and more guided and directed and focused therapeutic approach in care of the patient. And also, it is being more rationally if it is being better used with the more rationally critical thinking and clinical judgment approach with the correlation between the clinical condition, which help us in choosing the better available test, which can use for the betterment of our patient. So the common laboratory investigation, which is being carried out in the ICU setting, are ABG, which is being arterial blood analysis, complete blood count, renal function test, liver function test, coagulation profile, cardiac biomarkers, sepsis marker, electrolyte and metabolic monitoring, microbiological investigations, and point of care testing. So we'll talk about each of these investigation in detail in further slides. So let's target first the arterial blood gas analysis, which is being the ABG analysis. So as you know that ABG analysis is one of the most essential investigation in ICU, and it provides the rapid information about the patient oxygenation, ventilation, and acid-base status. So it directly guides that what decision we have to take in saving the life of the critically ill patient. So the physiological parameters which ABZ analyze are pH. So as we know that the normal pH ranges between 7.35 to 7.5, 7.45, which basically indicate the acid-base balance among the patient. Another physiological parameter which is being very crucial in ABG analysis is partial pressure of carbon dioxide, which ranges between 35 to 45 mmHg, and it is a respiratory component which reflect about the respiratory functionality of the patient, how well the respiratory component is functioning. Now, next parameter, physiological important key parameter is being bicarbonate anion, and the normal ranges from 22 to 26 milliequivalent per liter. And basically, it reflects the metabolic component of the acid-base balance. Partial pressure of oxygenation, which is which ranges between 80 to 100 mm of Hg, and it tests the oxygenation status of the patient. And lastly, the saturation of oxygen, which is being in percentage, and it ranges normally between 95% to 100%. So now why the ABG is done? What is the main indication of ABG in ICU setting? So as you all know that in ICU setting is an area where we are being with the critically ill patient, and majority of patients are encountering the respiratory distress, ARDS, ALI, acute lung injury. Patients are on mechanical ventilator. So we need to, how well the patient are working with the mechanical ventilators. Patient are being with the sepsis and the shock. Patient who are having cardiac arrest. Patient with metabolic disorder like diabetic ketoacidosis and renal failure. Or a patient with the drug overdose or opioid poisoning or etc. So all these patients require acid-base balance monitoring, and that can be only achieved by ABG analysis. So it helps in detecting the deterioration before clinical sign worsen. So before the patient critically went into into a severe condition, it before that only it tells us that how we have to act and how we have to correct all those physiological parameters so that we can save the life of our patient at early point. So there is a stepwise ABG interpretation, which we all should know that is very crucial for all of us to know. And this stepwise ABG interpretation not only identify early acid-base imbalance, but also help us and guide us in acting in early stage itself that how we can correct all these parameters. So the first check and the first parameter which we should look in ABG is the checking for pH. So as we have seen in the previous slide that the normal pH range is between 7.35 to 7.45. So any deviation from this normal range will indicate that patient is having what condition. So if the patient is having the pH less than 7.35, then it will indicate that patient is being at risk of having acidosis or patient is having acidosis. And if the patient is having a pH more than 0.45, then patient is being ending up into alkalosis. So after checking pH, now we have to identify the primary cause. What is the component? Which component is affecting the patient condition, whether the respiratory component or the metabolic component? So to understand the primary cause, we have to now look for the partial pressure of carbon dioxide, and also we have to look for the bicarbonate anion. So first we will look for the partial pressure of carbon dioxide, in which we'll see the partial pressure of carbon dioxide range in the ABG strip of the patient. So if the partial pressure of carbon dioxide is high in the patient, then patient will be having respiratory acidosis. If the partial pressure of CO2 will be low, means less than 35 mm of Hg, then patient will be at risk of having respiratory alkalosis. So same like with the bicarbonate anion. If the patient is having bicarbonate anion less than 22 milliequivalent per deciliter, then patient will be at risk of having metabolic acidosis. And if there is high bicarbonate anion more than 28 milliequivalent per liter, then patient will be at risk of having metabolic alkalosis. So to learn this and to keep this criteria in mind, these are ROM criteria, ROM rule. This is a mnemonic you can use, and you can go through this mnemonic to keep the criteria, how to understand the patient condition. So Rome rule says that respiratory opposite means to have the respiratory acidosis. If the patient pH is being low and the PaCO2 is increased, then patient is at risk of having the respiratory acidosis. And for metabolic component, the both components should be equal. Means pH should be raised and bicarbonate anion should be raised. Then patient will be at risk of having metabolic alkalosis. And if the pH will be decreased and bicarbonate anion will be decreased, then patient is at risk of having metabolic acidosis. So the ROM criteria will help us to know and will guide us that what component and what involvement the patient might is having, whether it's the respiratory acidosis or alkalosis or metabolic acidosis or alkalosis. Now the third criteria is for checking compensation. So opposite parameters in this in compensation, you will see that opposite parameters will try to compensate to bring the pH in the normalize. So when you know that patient is being at risk of acidosis, so to compensate the acidosis, the bicarbonate anion will try to compensate. So you will see there is a decrease in the bicarbonate anion. Then you will think that yes, compensation started, because bicarbonate anion is basically having the base effect. And to compensate the acidosis, the bicarbonate anion has to come up. So there will be a decrease in bicarbonate anion. So we have to now look for the compensation. And the last check is for assessing the oxygenation. So for assessing the oxygenation, we have to look for the partial pressure of oxygen. And if the partial pressure of oxygen is being less than 80 mm of Hg, then patient is being at risk of having hypoxemia. Now, if you talk about more in detail about compensation, then we have partially compensated conditions, both metabolic acidosis and both metabolic alkalosis. So I'll be telling you regarding metabolic acidosis. So once you get through metabolic acidosis, then it's easy to understand the metabolic alkalosis. So in partially compensated metabolic acidosis, the pH will be decreased, means the pH will be less than 7.35. So pH less than 7.35 will indicate acidosis. So first check we have done through the pH. Now second check, we have to look for the partial pressure of CO2. So in this, what we will see the partial pressure of CO2. So if the partial pressure of CO2 is less than 35 mm of Hg, then we will see that there is a compensation started by lungs. So patient will be having PaCO2 less than 3 mm of Hg. Now we have to go for the third check. And the third check is being regarding the bicarbonate anion. So bicarbonate anion, we have to see that what value the bicarbonate anion the patient is having. If the bicarbonate anion values is being less than 22 milliequivalent per liter, then you will start thinking that the compensation mechanism started. Metabolic involvement has started. So there will be a primary problem. And so if the bicarbonate anion is less, suppose in this condition the patient is having 15 milliequivalent per liter. So, and the last component you have to look for the PaO2. So if the PaO2, that is partial pressure of oxygen, is normal, within the normal range, then you can say that patient is being at partial compensated metabolic condition, acidosis condition. So like this, you have to look for the compensation. So to compensate the acidosis, to compensate the um, PaCO2 and to compensate the acidosis, what have started? The compensation through the lungs have started, and the compensation through bicarbonate anion have been started. Now, the second compensation is compensated complete compensation, which is being known as the advanced stage. So again, in this, I have taken an example of metabolic acidosis so that you can understand. So in this condition, what you will see that patient pH will be within the normal range, means either within the normal range or bit toward the acidic side. Not that much huge difference you will see, but you will see a slight deviation toward the acidic side. Then second component will look for the partial pressure of CO2. So in this you will see that the compensation by the lungs. So you will see a decrease in PaCO2 less than 35 mm of Hg. And the third check you will look for the bicarbonate anion. So again you will see that bicarbonate anion will also be decreased. Means the complete compensation has been carried out by both respiratory component and metabolic component to cover up the acidosis condition of the patient. So when you will see that both the component are being acting to compensate the acidosis, then it is known as the compensating metabolic acidosis with the pH either within the normal range or toward the acidic side. So here pH will appear normal, but both PaCO2 and bicarbonate anion are abnormal, means in the full compensation mode to compensate the acidosis condition of the patient. So that time we will say that patient is being having compensated metabolic acidosis. Now, what are the nursing responsibility with ABG? So now we have seen the four checks that how to interpret the ABG. So once we are having ABG strip in our hand of the patient, first we have to have uh, the clinical condition. First, we should be knowing the clinical condition of the patient. We should be having the history of the patient. We should be knowing that what is the diagnosis of the patient, what happened to the patient, because that will indicate and that assessment will let you understand more about the ABG of the patient. So first you have assessment, and you should be knowing the indication of ABG for the patient, whether the patient is being on sepsis, whether the patient is being having shock, yeah, whether the patient is on mechanical ventilator, is unable to cope with the mechanical ventilator, and we want to know the ABG status of the patient. That's why we have undergone the ABG test for the patient. So that detailed history and physical assessment of the patient you should be having with yourself to understand the ABG of the patient. So once you have assessed and consider the indication of ABG for the patient, now you have to start your responsibility. So there is a pre-procedure responsibility, being a nurse to the patient, and that those responsibility is that first you have to explain the procedure to the patient. As you all know that ABG is a painful procedure, no doubt, and you are taking a blood from the artery, and the patient is too anxious. When the patient is being in the hospital setting, the anxiety itself increase. So being a healthcare professional, we have to understand the psychological status of our patient, and we have to accordingly provide care to the patient. So explaining the procedure is one of the step going near to the patient to support psychologically and to relieve their anxiety so that they can cooperate with you and you can easily carry out the test on your patient. So you have to explain in detail the procedure to your patient, so to reduce their anxiety and so that they can cooperate with you. Then after that, you have to perform the LN test. And as you all know that LN test is being performed to assess the collateral circulation. So until unless the LN test come positive, you can't proceed for ABG analysis. So it tells whether your body collateral circulation is being patent or not. If any of the circulation is hampered, then we have to drop the test from that particular site. We can use another site. So suppose if we are performing the radial artery ABG analysis, so we have to perform the LN test in the hand on the hand by compressing the ulnar artery and the radial artery and to see the advocacy of the collateral circulation before having the radial puncture. So after performing the LN test, and once you have seen that patient is having both the collateral circulation patent, now you have to ensure the proper positioning and asepsis since it's an invasive procedure and we are going into the artery, so we have to follow the aseptic technique so that none of the patient get infection because of us. And after that, we have to prepare the equipments. So preparation of the equipment should be done prior before picking, no doubt. So in this, we should be having the heparinized syringe. We should have ice with us. We should have all the personal protective equipment with us before picking the patient. Now, the third nursing responsibility is the sample collection and handling. So we have to assist and perform arterial puncture and draw from the arterial line. So if we are assisting, then we have to ensure that all the measures, aseptic measures are being done, all the preparation is done prior or not. And if you are performing by yourself, then you have to ensure all those checkpoints which I have told you now. So before going inside the artery, what we have to ensure is that maintain no air bubble. Means we have to ensure that our syringe should not have any air bubble because if any air bubble will be there, then it will alter the finding of the ABG because that partial pressure, that atmospheric partial pressure will cause alteration in the partial pressure values of CO2 and O2 in the patient blood sample. So we have to ensure that there should be no air bubble in the syringe. There should be proper heparinization so that blood should not get clotted and coagulated. And also the immediate transport is a important point in ABG. That is true within 10 to 30 minutes. And why it is being said so? Because as you all know that our blood have our own RBCs and leukocytes. And after being drawn up also those RBCs and WBCs, they have their own cellular activities that goes through. So once the blood is being drawn up and that cellular activity will also will be there in the syringe. That will result in consumption of more of the O2 and production of more of the CO2. So it will falsely give you the result toward the acidosis side. So we have to ensure the fast and immediate transportation of the ABG blood sample. So to get any false interpretation, false results for the patients, and that too within 10 to 30 minutes. Also, if you see that any delay is there, then you can use ice also, but that should be avoided. Ice will basically helps in slowing the cellular metabolism, which will slightly help you in alteration, in non-alteration of the findings of the patient. But ensure that it should be transported within 10 to 30 minutes. Now, once the ABG is sample collected and it is being transported as per the protocol, now the important point becomes the ABG interpretation. So, as I already told you, that ABG interpretation should be known by everybody of us, irrespective of the profession, because early recognition will prevent the clinical iteration of the patient. So, you should have at least those four checks of ABG interpretation in which we have to look for the pH, we have to look for the PaCO2, we have to look for the bicarbonate anion, then we have to look for the PaO2 and the compensation too. Although there is much more about ABG in which we have to look for the base deficit, we have to look for the anion gap, but that is being more detailed, which I think ABG will take furthermore to our class and which I won't be able to cover in this session. So, but that four simple check you should be knowing so that you can early identify the patient condition and you can start the treatment for the patient. Now, next parameter, next nursing responsibility, once you have interpreted the APG, now comes the clinical decision that what to do. Once we have seen that patient is being ended into acidosis, patient is not able to work up with the ventilator modes which you have provided, then you have to s- take your decision based on your BG findings. What you have to do, whether you have to initiate or adjust the oxygen therapy, whether you have to change the mechanical ventilation modes, whether you assess, whether you need the treatment change for the patient. So this will be supported through your ABG interpretation. Now, next point is monitoring and trend analysis. So for having the monitoring and trend analysis, you should have a serial ABG monitoring. So each ABG, what you are being doing for your patient should be recorded and documented properly so that you can understand the trend. You can understand the prognosis of the treatment of the patient. And accordingly, you can revise and you can change the treatment regimen for your patient. You have to compare the trend and the trend can't be compared not just with single values. So for that, we should have a multiple ABG report with you so that you can detect early deterioration and you can act early for your patient. Communication collaboration is a vital parameter. So no doubt, once you got the ABG in your hand and once you get an indication of the clinical iteration, you have to collab with your intensivist. You have to give them a call that to come and act upon fast and help them in their decision support making. So for the betterment of the patient. Documentation, as I already said, because we have to have a trend analysis, we have to have a monitoring each time for the patient, then documentation is the crucial parameter and the nursing responsibility. And lastly, the patient safety and education. So in this, we have to ensure patient safety parameter also, and we also have to educate to our patient regarding their outcomes. Now coming to the next lab investigation values, which is being very frequently ordered and rapidly available in the ICU, and that investigation is complete blood count. So it provides a crucial insight into the infection status, oxygen carrying capacity, coagulation profile, and overall physiological response to the illness of the ICU care patient. And the components of CPC and their ICU significance uh, includes hemoglobin or hematocrit. So as you all know that the normal hemoglobin ranges between approximately 12 to 16 gram per deciliter among female and 13 to 17 gram per deciliter among male. So if we talk about the importance of hemoglobin in ICU setting, then it will help in detecting the anemia. So, if the patient is having less than 12 gram of deciliter, suppose the patient is female and patient is having less than 12 gram of deciliter of hemoglobin, then patient might be anemic. And for anemic patient, you know that there is being always oxygen carrying difficulty, and you have to ensure a proper oxygenation to the tissues and the cells. So it will affect the oxygen delivery, and accordingly, you have to ensure the oxygen parameter for the patient. You have to look for the blood transfusion. That if the patient is being having the severe anemia, less than 6 gram per deciliter, then you have to start think of the blood transfusion to the patient for the patient betterment. So it will not only detect anemia but also guide in blood transfusion, also monitors the bleeding. So sometimes there is an internal bleeding which is being hidden, which is being concealed, and are not able to identify, and patient is being going into hypovolemic shock. So this can be easily interpreted and fastly detected through the CBC and through the hemoglobin. Now the next component of CBC is the white blood cell, which is also the soldier cells of our body. And the normal range, as you all know, that ranges from 4,000 to 11,000 per millimeter cubic. So if you talk about the ICU significance of the WBC, so increase in WBC will indicate to that patient might be having infection or patient might be having any type of inflammation or patient it will be in any type of sepsis. So accordingly, you can start your antimicrobial therapy. Accordingly, you can start the anti-inflammatory drugs to the patient. And decrease in WBC will indicate you immunosuppression or bone marrow failure. Now, the third component in CBC is differential leukocyte count, DLC. And in this, the main component which we look in the CBC reports are neutrophils, lymphocyte, eosinophils. So if there will be increase in neutrophils, then you will think of that patient might be having any type of bacterial infection. Or if there is an increase in lymphocyte, then you will think that patient might be having any type of viral infection. And if the patient is having eosinophil increase, then you will think that patient might be having any type of allergy. That the patient might be having any type of parasitic infection. So it will give you a guidance that what therapy to start to the patient. So each component plays a vital, no doubt. Now the fourth component is platelet count. So as you all know that the normal platelet count ranges from 1,50,000 to 4 lakh per millimeter cubic. And the importance of platelet in ICU setting is that increase in platelet will tell you the inflammation or the reactive states. Reactive states like reactive thrombolysis. So that will indicate you that what to start and how to start to the patient. So that that cascade can be stopped. And decrease in platelet will tell you the patient is at risk of bleeding, or patient is having disseminated idiopathic coagulopathy, or the patient is being in the sepsis. So accordingly, you can start a treatment regimen for your patient. So those uh, vital parameter again in the management of the patient. Now the nursing role in CBC monitoring is being uh, timely sample collection. So as per ordered, we should collect the sample on the timely basis. We should know the normal range because until unless we don't know the normal range, we won't be able to understand the abnormal values. We have to understand the abnormal values early and act accordingly. Then we have to monitor the trends and report changes. Monitoring trends is very crucial component in ICU care because it will tell you the prognosis of the patient. It will reflect you how the treatment regimen and guide you how the patient is working up with the treatment which we are providing to the patient. Where then we have to observe for clinical correlation such as bleeding, infection, and sign, which can be reflected through the vital parameters with the temperature, with the ultrasensorium. So this can be correlated with CBC and proper documentation. So all these are the nursing role in CBC monitoring. Now, our third lab investigation, which is being again a vital in ICU, because as you all know that kidney function plays a major role in ICU care. Because kidney function will let you know how the fluid balance is going on in the patient, how the electrolyte stability is being working for the patient, the drug which you have given is whether it's been clearing through properly or not, metabolized properly or not. And you all know that majority of our drugs are being metabolized in the kidney and in the liver. So kidney function plays a vital parameter in ICU setting. And also it will give you an overall survival of the patient. So renal function test is a vital parameter. And even a subtle abnormalities can signal early deterioration in critically ill patient. So closely monitoring of renal function test is very crucial for being a healthcare professional. The component which we usually measure in the renal function test are serum creatinine, blood urea, electrolytes in which we have sodium, potassium, and chlorides. Then we have various criteria for acute kidney injuries like Kadigo criteria, Atkin criteria, Rifle criteria. So I'll be telling you one criteria right now in the further slides. And the most important parameter is urine output monitoring, and which should be strictly done by each of us, being a nursing professional, to help our intensivist. So this is the critical criteria in which you can see the two criteria is being used to identify the patient is being in at what stage of AKI, whether the patient is in stage 1, 2, or 3 of AKI. So if the patient is in stage 1 of AKI, then you will look for the serum creatinine and the urine output. So, if the serum creatinine of the patient increases to more than equal to 1.5 to 1.9 time of the baseline serum creatinine, and the patient urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, then you will say that patient is at stage 1 of AKI, and you can start accordingly the treatment regimen for the patient of the AKI management. And if the patient in the stage two of AKI, then there will be increase in serum creatinine 2 to 2.9 times from baseline serum creatinine. And again, the urine output will be less than 0.5 ml per kg per hour for more than equal to 12 hours. So in stage 3, when we say that there is a increase in serum creatinine more than equal to 3 times of baseline serum creatinine, then you have to no doubt start thinking of the renal replacement therapy irrespective of the stage for preventing the clinical iteration of the patient and the recovery of the patient. And you will also observe that patient will be having less than 0.3 ml per kg per hour uh, urine output for more than equal to 24 hour, or there will be anuria for more than equal to 12 hours for the patient. So like this, you have to use any of the standardized tool to understand the patient is being in what stage of AKI so that you can start the treatment regimen accordingly for the patient in collaboration with your intensivist and the physician. Now, what is the nursing responsibility? So, in RFT, nursing responsibility, I think, is a crucial parameter and component because, as you all have seen that in previous criteria, along with serum creatinine, the urine output also plays a major role. And the urine output is being intake output monitoring only. And that is mainly being done by our nurses only, being 24 by 7 available for our patient. So it is very crucial for all of us to have a strict intake output charting for the patient to help our intensive to understand the condition of the patient. We have to monitor the urine output on hourly basis. We have to identify the abnormal values early. We have to look for the serum creatinine. So what is the serum creatinine? Whether the serum creatinine increases to how much time, so that accordingly we can understand that patient is at what stage of AKI. We have to report for any electrolyte imbalance, and mainly the patient that AKI या फिर in the renal failure at mainly risk of having hyperkalemia, which is a life-threatening situation. We have to report it immediately to save our patient life. And we being the angel, we and in the forefront, we have to very vigilant for these parameters, no doubt. Then we have to ensure proper fluid management, and that can be overcome with the fluid that we are giving to the patient. And also we have to assess in dialysis preparation for the patient if we found that patient is at phase 3 of AKI, right? So no doubt, nurses plays a tremendous role in RFT monitoring, and we have to be very vigilant. Now the next parameter, like next lab investigation in ICU setting is liver function test. So after RFT, now we have to move for liver function test. So it is essential because it assesses the hepatic injury, the synthetic capacity, the metabolic function, and the prognosis of the patient. So liver dysfunction critically patient is majority of time are multifactorial. Might be because of sepsis, might be because of the drug which we are being given to the patient, might be because of the shock. So early identifying the abnormal values in the LFT reports will indicate you that the patient is going toward the organ failure, so that you can early identify and you can early start the treatment regimen for the patient. So whether you have to start the shock treatment regimen, whether you have to taper the drug, whether you have to change the drug, yeah, whether you have to control the sepsis. So all this can be done through the LFT. Now the key component of LFT are, the first one is bilirubin, in which we look for both the total and the direct bilirubin. So as you all know that total normal bilirubin value ranges approximately between 0.3 to 1.2 milligram per deciliter. And if the patient is having total bilirubin more than 1.2 milligram per deciliter, then it will tell you that patient is having either jaundice, the patient is having cholestasis, the patient is having sepsis, related liver dysfunction. Now, the second important component is transaminase, which is being aspartate transaminase, या फिर alanine transaminase, which is AST and ALT, also known as SGO2 and SGPT, which mainly reflects the hepatocellular injury the patient might be having because of the disease condition. So if there's a significant increase in AST and ALT enzyme, then patient is being at risk of ischemic hepatitis, which is also known as a shock liver. Yeah, if patient is being going through the drug toxicity, because as you all know, and I have told you previously also, that majority of drug metabolism happens in liver and kidney, and both of the functionality will tell the prognosis of the patient. And if there's a mild to moderate increase in AST and ALT, then it will suggest that patient might be having infection and the inflammation, so that accordingly we can start the treatment regimen. Now, the third component of the LFT is being alkaline phosphatase, which is being a marker of cholestasis or biliary obstruction. And if there is increase in alkaline phosphatase, then it will tell you that patient might be having obstructive or sepsis-related cholestasis. So you can accordingly start the treatment for the patient so that cholestasis can be relieved, that obstruction can be relieved, that sepsis-related cholestasis can be cured so that we can prevent the clinical iteration of the patient. The fourth component is the albumin, and as you all know that the normal value ranges between 3.5 to 5 gram per deciliter. And basically, it reflects the synthetic function, that how well the liver is being synthesizing the protein. So if the liver is being not functioning properly. There is a dysfunction in the liver. There is being injury in the liver. Then definitely there will be effect on the synthesis of the albumin, and patient will be having decrease in albumin. So which will reflect to the chronic illness, the malnutrition, and the liver dysfunction. So that is why it is important to understand all these components, their values, their deviation, so that you can understand that patient is having injury to the liver. Now we have to look for the liver, we have to care for the liver, and we have to start the regimen accordingly to prevent the patient condition. Now, the next in the lab investigation is the coagulation profile. So it is very critical investigation in ICU setting, no doubt, because it assesses the patient bleeding risk, the clotting status, and also the severity of illness. And it is especially very important in conditions like sepsis, trauma, liver failure, and post-surgical care. Now, the key components of coagulation profile are thrombin time and INR, that is being international normalized rate. So, as you all know, that the normal PT ranges between approximately 11 to 14 seconds, and the normal INR ranges from approximately 0.8 to 1.2 seconds. So, if any deviation happen in these ranges, then it will tell you that there might be some injury, there might be some effect in the extrinsic pathway of the coagulation profile of the patient, which led to the common pathway. And because of that hamper in the extrinsic pathway, the patient is being having the deranged PT and INR. So it will reflect you that patient might be having any liver disease, the patient might be having any vitamin K deficiency, the patient is being, on anticoagulant use, which is warfarin use, so you have to think of tapering it off. So we have to look for the PTNR value, no doubt, among the patient. So, now the second component in coagulation marker is being activated partial thromboplastin time, so which is also known as APTT, and the normal value range is approximately between 25 to 35 seconds. And it evaluates mainly the intrinsic pathway in which factor 7, factor 11, 12 came, which led to the common pathway. And any increase in APTT will tell you that patient might be on heparin therapy, and we have to think of tapering it. Patient might be having any coagulation factor deficiency, and we have to consider that coagulation deficiency factor, and we have to initiate that to the patient. So to ensure this uh, pathway can be regulated properly, and patient might have any coagulation abnormality, because increase in the values will result in delay in coagulation among the patient, delay in clotting among the patient, again, which is being an issue in management to the patient. Now, the third component is fibrinogen, which have the normal in between 200 to 400 milligram per deciliter, and it is an important clotting protein, no doubt. And if the fibrinogen is being decreased in the patient, then patient is at risk of having disseminated idiopathic coagulopathy. Patient might be having severe liver disease, because you know that mainly most of the common pathway of this clotting factor happens in the liver. So this will indicate that liver need our care, and we have to think of that. Now the fourth component is D-dimer, which is a marker of clot breakdown, fibrinolysis. And if the patient is having PCD dimer, again, the patient is at risk of having bleeding, DIC, thrombosis, या फिर sepsis. So we have to think of that, and then accordingly we have to start giving regimen to the patient. Now, the next lab investigation is cardiac biomarker, which is again an essential laboratory investigations. And you know that majority of time ICU is being encountered with cardiac arrest patient, and it's important to understand the cardiac biomarker to understand the myocardial condition of the patient, the cardiac stress of the patient, and also to know the prognosis of the patient. So they help in early diagnosis, no doubt, risk stratification, and guiding decision to the intensivist and to the healthcare professionals. Now, the key cardiac biomarkers which you should know and which is essential for you to know are cardiac troponins, in which we have cardiac troponin I and cardiac troponin T. So they are the most sensitive and specific marker of myocardial injury, and they usually rise 3 to 6 hours after injury. And the peak comes 12 to 24 hours of injury and remain elevated for 7 to 14 days. So if you will found that patient is having elevated this troponin I or troponin T, then patient might be having acute myocardial infarction, या फिर patient might be having sepsis-related cardiac injury and heart failure. Now next marker is being CKMB. CKMB again is an early marker, but it is being less specific than troponin. It rises 3 to 6 hours and normalized in 48 to 72 hours. And the main use of CKMB is being detecting the reinfarction. So yes, we have to look for that also. CKMB again is a heart marker, biomarker, the marker which is being released by our heart. Now, the third cardiac biomarker is being the BNP, natriuretic peptide, and natriuretic T segment pro-BNP, B-type natriuretic peptide. So again, it's a cardiac biomarker and basically released by our ventricular myocardium. So this is released when there is a stretch in the ventricular myocardium and when the cardiac stretch and when there is a heart failure. So whenever there will be any defect and any afterload issue or any heart failure issue in the patient, then BNP value gets raised in the patient. So it will indicate you that patient is ending up into heart failure, your patient is being having the fluid overload, and you have to think of giving the fluid to the patient. It mainly helps in differentiating the cardiac versus respiratory dyspnea and also tells about the prognosis of ICU patient, that how prognosis of the patient will happen in the patient, whether the patient will go to the good prognosis or the patient will end up having the poor prognosis. So this can be looked by the BNP cardiac biomarker. Now the fourth cardiac biomarker is the myoglobin. So although it's the earliest marker, which usually rise in the patient that is being between 1 to 2 hours, but we can say it is being low specific because of its low specificity. We consider it at the last only because as you know that myoglobin can be produced at the time of muscle breakdown also. So not mainly really because of the heart also. It can give you a false, a reading. So to be more specific, you have to go for troponin T to consider the cardiac injury, no doubt. Now, the next lab investigation, which has been very important and vital to consider in the ICU setting, is the sepsis marker. As we know that a sepsis is a life-threatening organ dysfunction caused by dysregulatory response to infection. And in ICU, laboratory biomarkers are very crucial for early diagnosis, severity assessment, and monitoring response to treatment. So the key specific sepsis markers are procalcitonin. So it's a more specific marker for bacterial infection, and it rises within 4 to 6 hours and peaks at 12 to 24 hours. So if the procalcitonin values are high, then it will suggest you that patient might be having bacterial sepsis, patient has been in the septic shock, and will help you also in starting the antibiotic therapy to the patient, and also will let you know when to de-escalate the therapy. Now, the second sepsis marker is the C-reactive protein, which is also known as CRP. Again, it is a marker of inflammation and it rises within 6 to 8 hours. It is less specific than PCT, but yes, it is though a vital parameter to understand the sepsis among the patient and to know the inflammation among the patient. It is useful for monitoring the progression and response to the treatment. So we have to understand and we have to monitor the trends of this marker also whenever we are looking for the sepsis marker and we are treating the sepsis of the patient in ICU setting. Now the third component in sepsis marker is serum lactate, which basically measures the tissue hypoxia and perfusion, and the normal range is less than 2 millimole per liter. So if the patient is having range more than equal to 4 millimole per liter, then patient is at risk of having severe sepsis and stroke. And it is a strong prognostic indicator regarding the prognosis of the patient condition. So we have to consider serum lactate, no doubt. Now the fourth component is interleukin, such as interleukin 6, which is the early inflammatory marker, and it rises very early in the sepsis. So we have to consider that and we have to understand at how to give care to the patient. Now, the next lab investigation is electrolyte and metabolic monitoring, which is being a cornerstone in ICU care. And even minor imbalance will rapidly lead to cardiac arrhythmia, the neurological deterioration, the multiple organ failure. So, continuous assessment will not only allow early detection, will also will also have help in timely correction and prevention of complication to the patient. So the important electrolyte which we consider and which you all should know in ICU are first is sodium. So basically, which reflects the fluid status and also which reflects the brain functionality of the patient. So if the patient, as you all know, that the sodium normal range ranges between 135 to 145 milliequivalent per liter. And if this ranges get deviation, if the patient is having less than 135 milliequivalent per liter sodium in the blood, then you can think the patient is at risk of having hyponatremia. If the patient had hyponatremia, so you have to now understand the cause. What had led to that hyponatremia, whether it's SIDH, which is being systematic inflammatory antidiuretic syndrome of idiopathic antidiuretic hormone, which have led to that. या फिर whether it's a fluid overload, which have led to hyponatremia. So accordingly, you have to taper the fluid. Accordingly, you have to treat the SIDH with the hormone replacement therapy. And how will you come to know how you will correlate this with clinically? That patient will be having confusion, patient will show these signs and symptoms of seizures. So you will get an idea that patient have alteration in sodium electrolyte. When the patient is having more than 145 milliequivalent per liter of the sodium in the blood, then it will indicate that patient is dehydrated and we have to start the fluid to the patient. And the increase in sodium will result in alteration in mental status of the patient, no doubt. So their management again is very crucial, although this is not being covered by me in the slides that you will see, I think, in further slides by other speaker. But what you should know is the normal values of these electrolytes and what signs and symptoms the patient will show you, so that you can start early treatment regimen to the patient to cure these deficits. Now, the second important electrolyte is potassium, which mainly tells the cardiac stability, and the normal ranges between 3.5 to 5 milliequivalent per liter. So, if the patient is having hypokalemia, in that you will see that patient will be having potassium range less than 3.5 milliequivalent per liter. And as you all know, that majority of the patient in ICU setting have diuretics, so you have to consider the diuretic, whether the diuretic have not resulted in hypokalemia to the patient, so that you can stop, yeah, you can change the diuretic according to the patient condition. You can tell your physician early to consider that thing so that patient can't end up into hypokalemia. Because once the patient end up into hypokalemia, then patient will be at risk of having arrhythmia, muscle weakness, further worsening the patient disease condition. So early identification of imbalance in this electrolyte will further uh, prevent the complication of the patient. So you should consider all these parameters, no doubt. In hyperkalemia, if the value is being more than 5.5 milliequivalent, then you have to think for the cause of renal failure, and you have to think of the if it is being suggested by the intensivist, then you have to also think of refractory hyperkalemia of renal replacement therapy, yeah, for dialysis for the patient. Then you have to start for preparation for the dialysis. So all this you have to consider, and for that you should be knowing that how important to know the imbalance in the electrolyte, because if they are not detected early, then definitely the patient will end up into life-threatening arrhythmias, and you will lose the patient, which might could be prevented into ending up to life-threatening condition because of our observation and because of monitoring of the trends. Now, the third electrolyte is being the calcium, which is mainly for neuromuscular functionality. And the normal value ranges between 8.5 to 10.5 milligram per deciliter. So if the patient is having low calcium, then patient will be having tetany and the seizure. And if there is a high calcium, then patient will be having confusion and cardiac issue, further leading to poor prognosis and further complicating the prognostic factor of the patient. So you have to very vigilant about these electrolytes. Now, magnesium is important for cardiac arrhythmia, and if the patient is having low magnesium, then they will be patient at risk of having arrhythmias, and if the patient is having high magnesium, then patient is at risk of having respiratory depression. Now, the fifth electrolyte which is important for you to know is chloride. As you all know that it maintains the acid-base balance, and any deviation in the chloride will result in acidosis and acidosis among the patient. If you talk about metabolic parameter, then blood glucose monitoring is a vital parameter in our metabolic aspects in ICU patient. And for ICU patient, we should have a normal target ranges approximately between 140 to 180 milligram per deciliter. So if the patient is hyperglycemia, then they will be at more risk of having infection and further complicating the condition. And if the patient is being in the hypoglycemia, then patient will be having brain injury. So both we have to prevent that patient don't end up into both of the condition. Microbiological investigation. Again, it's an important lab investigation in which blood, urine, sputum culture collection. You should know how to collect blood sample, how to collect urine sample, how to collect sputum culture, how to transport them, when to collect them, where to collect them, how to ensure asepsis while collecting them. It is important being a nurse and a healthcare professional because if they are not collected properly, then you will end up into having a false results and further delay in the patient, treatment regimen. So we have to be very peculiar and particular whenever we are collecting the microbiological investigation samples. Then PCR-based rapid diagnostic, which will help you in identifying the microorganism the patient is affected with, and you can start accordingly the treatment regimen. Fungal marker if indicated. So all this come under microbiological investigation. Now, endocrine and spatial test. So they are the crucial for identifying hormonal imbalance, metabolic crisis, and hidden systemic dysfunction that can significantly impact patient survival. So the common endocrine tests performed in ICU setting are thyroid function test, and the ICU patient are at risk of having mainly hypothyroidism. Cortisol adrenal insufficiency test for both inflammation and electrolyte imbalance correction. We look for cortisol adrenal insufficiency. Then serum osmolarity to assess the fluid and electrolyte disorder, which is useful in hyponatremia and poisoning treatment. Toxicology screening, if indicated for detecting drug overdose and poisoning. So all these tests are also important lab investigation parameters which are being carried out in the ICU setting. You all should be knowing that where to send the samples, how to collect the samples, what all the forms, how to fill the forms, where to send, how to look, in which condition, what test we have to apply, because that is also plays a vital role. That what clinical condition require what test. Now, the point of care testing. So, as you all know, that point of care testing refers to a diagnostic test which we perform at or near the patient bedside in the ICU, which provides rapid results to guide immediate clinical decision. And in those, we usually have, and the importance of rapid point of care testing is that, first of all, rapid decision making, which is very crucial and important parameter in critical ill patient. Because if we won't act rapidly, we might lose patient from our hand, and we don't really want that. Early detection of deterioration, again, because of that, the point of care testing is important in the ICU setting. It reduced turnaround time compared to the central lab because for central lab we have to wait. We have to send the sample to the central lab, then we have to wait for the result. But because of point of care testing, we can immediately get the reports in our hand then and there itself. So it saves the times and those saves the patient life. It's support real-time monitoring. It's helping monitoring the trends, no doubt. And it's also improve patient outcome through timely intervention. So that is why it is important to have point of care testing in ICU setting. And the example of point of care testing mainly are bedside ABGs, glucometer, portable lactate monitors, etc. So I think majority of us are having all these point of care testing, diagnostic tests in our ICU settings which help in early detection of the patient iteration and improving patient outcome, no doubt. Now, role of nurse in POCT is being proper sample collection and its handling, no doubt. So, as I already told you, how to collect the ABG sample, within how many minutes we have to go through the analysis so that we don't have any false reading, interpretation. We should know the device calibration and also have a quality control parameters. We should have a correct patient identification, no doubt, because the patient is not correctly identified, then we end up being the wrong treatment regimen for the patient, and we really don't want that. Interpreting and promptly reporting abnormal values and understanding the trends, maintaining infection control practice, that is a vital parameter for us because we don't want any nosocomial infection because of us to our patient, and documentation and communication with the team. So these are the main important role of nurse whenever we are working with the point of care testing in the ICU setting with the patient. So finally, concluding my lab investigation, lab diagnosis is the cornerstone of ICU management. Early detection improves outcome. It is rational and cost-effective testing, no doubt. Nurses plays a key role in lab-based decision making. Early detection prevents complication, proper documentation improves patient safety, and teamwork improve ICU outcome. So to early detect the patient and to prevent the clinical deterioration of patient, the lab investigation is very important vital parameter in ICU setting. And we all have to come forward, we all have to collab to each other, we all have to use our skills to ensure the betterment of the patient. And for that only we are here, I think. So these are my references. Thank you for your attention.